Hi, my name is Courtney Addison. I'm a master's student in the Department of Anthropology, and I am very pleased to be speaking to you this evening about a part of my master's project. In its entirety, my research is looking at the personal and interpersonal aspects of living with chronic fatigue syndrome, which I'll refer to from now on as CFS, just for brevity's sake. So today I'm focusing on one part of my research, which explores the coping strategies of people with CFS. I situate these within broader discussions of autonomy and responsibilization, and I question how people's coping might be characterized as a form of self-management or alternatively encapsulated in ideas of care. And I think that this is actually really important because CFS sufferers are underrepresented in the academic discourse developing around their condition, despite having a wealth of lived knowledge on the matter. CFS affects 20,000 New Zealanders. It is debilitating. Sufferers are often housebound for months or years. It's poorly understood, both scientifically and publicly, which has huge implications for its treatment. The primary symptom is fatigue, sustained for 6 months or more, and dramatically exacerbated by exertion. Muscle pain, sleep problems, headaches, tender lymph nodes, impaired concentration, depression and anxiety are other symptoms commonly reported. And all of these things vary from person to person and from day to day. Moreover, neither a cause nor a cure has been definitively identified for CFS. So to understand what it's like to live with CFS, I held semi-structured interviews with 15 people who'd had CFS for between 1 and 25 years. These talks took place in my participants' homes. They took between 45 minutes and 3 hours and gave me a good sense of people's experiences of chronic fatigue. One of the most interesting outcomes of these talks to me, the part that I'm telling you about tonight, was when people spoke about how they were coping. This was something that I'd wanted to look at from the outset, and I decided early on that it might be useful to think about it in terms of self-management. In self-management programs, patients assume primary accountability for their health. This approach is characteristic of the New Zealand medical system, and it's actually also advocated by the International Association for CFS. Self-management recasts the patient-practitioner relationship. Patients actively seek out information on their health. They engage in more equitable relationships with their GPs. They negotiate. They monitor their health, keeping an eye on its ups and downs and adjusting their medication accordingly, without needing to consult a doctor every time. So the onus to obtain healthcare shifts from the state onto the individual. The physician is now a physician consultant, the patient, a patient expert, and a patient consumer. And this shift occurs as part of broader liberalising health reforms amidst a political climate that sees state accountability give way to individual autonomy. Sociologist Nicholas Rose writes about these broader movements using the notion of responsibilization, and especially relevant here, the responsibilized patient, that patient who is empowered or obliged to take care of themselves. So I began interviewing with self-management in the back of my mind, and as my fieldwork progressed, I identified 4 key strategies that people described as coping. Firstly, they were actively seeking out information on their health, online, in books, through their contacts, their support groups, and from their doctors when they knew enough to help them. And in doing this, they built up a reservoir of information on their condition that they used to both understand and explain CFS and also to live with it. This standardized advice was sometimes waived in favour of a second coping strategy, the privileging of embodied knowledge. After months, years, or even decades with CFS, most of my participants had developed an intimate awareness of their bodies. They can feel when they need to stop what they're doing, rest, and close their eyes. So one participant, Rosa, told me, we can feel it. Like, if I do too much reading, I can feel it rising in my head until it reaches a limit that I simply can't go over. And another, Lisa, said that just walking around her house, I could feel that if I didn't get down suddenly, I was just going to collapse on the floor. And so this deeply personal, embodied knowing often takes precedence over official advice. It also informs their third coping strategy, a behaviour that's known amongst the CFS community as pacing. Pacing involves people paying attention to their health and their energy, slowing down or spacing out their obligations accordingly. My participants told me how they would carefully plan out their weeks with one activity per day or perhaps every 2 or 3 days and plenty of rest time in between. The fourth way my participants coped with CFS was through a form of experimentality, by which I mean not an experiment in the normative scientific sense, but rather a process of everyday trial and error, highly individualised. My participants would test out different drugs and therapies to find those that best managed their illness in the context of their lives, often with less than desirable results. So for example, one woman I spoke with, Vicky, had been prescribed diet pills to manage her energy. And she'd actually tried 6 other medications in the year before we spoke to try and improve her sleep. And the diet pills were so rough that she actually now only takes them once a week for her daughter's Saturday soccer games. And she told me how she'd cut down all of those pharmaceuticals to the bare minimum whenever she started to feel well again. So these 4 coping strategies have some parallels with self-management. You have the informed patient, the collaborative patient-practitioner relationship, the adaptable treatment regime, where people's experimentality enables them to adjust how they cope according to how they feel. However, I encountered a serious limitation in applying self-management to CFS, because the majority of my participants had periods of illness where they were actually not self-managing at all. They were barely surviving. So we have here a quote from Rosa, and she had had CFS for 25 years by the time we spoke, and she'd been bedridden for 7 of those. And so she says, I could feel myself going down. That was the scariest because you never knew how far you would go, and you just have to stop doing anything. And for me, it meant absolutely nothing. It meant not turning over in bed. I couldn't open my eyes. I couldn't talk. I had difficulty even eating. And I had to turn really, really slowly because quick movements use too much energy. And so everything I did was very, very slow, and that was the only way I could cope. Self-management in times like this is not an option. So to really understand how people cope over the years with CFS, over the ups and downs, we need a little more than self-management. I suggest we look to care. Care is presently being rethought from within the social sciences, most notably in the work of Anne-Marie Moll, quoted, who's been publishing extensively on the topic. Moll argues for a shift in our logics of treatment, from a paradigm dominated by ideals of choice to one guided by care. My case here closely aligns with this, except that rather than choice, I begin with self-management, and note that both posit the patient as a rational and autonomous actor. I think here also of self-care in the manner described by Foucault in his analysis of the Greco-Roman practices of the South, a large part of which centred on care of one's health. And bringing these ideas back to my own work, I ask, what can a theory of care offer CFS that self-management overlooks? Care entails ongoing practices of attentiveness and adjustment, but these are more flexible than self-management. So even when Rosa was bedridden, unable to manage her health, she was able to care for herself to some small degree. She prayed, and she planned her healthy future, and these things were important to her. So here, care allows for a manner of coping that is oriented less around symptoms and more around oneself. Care also allows for an affective element that isn't accommodated by self-management, and learning to live with CFS is an intensely affective process. It is frustrating and heartbreaking and disorienting and depressing, and these are all things that my participants told me. But for many, it also triggers a process of discovery, of acceptance, and of empathy towards oneself and others. And this shifting emotional terrain of CFS profoundly shapes how people cope with it, both by guiding how they can care for themselves and whether they can or will accept care from others. And this is another possibility that the concept of care allows for, that care can come from outside of oneself. Care goes beyond the patient-practitioner relationship, privileged by self-management, and it travels instead along relational pathways of individuals relating to themselves and relating to their friends and their families and their partners. Care, then, may be a more useful way of thinking about CFS. Because yes, at times my participants did self-manage, but they did so in a deeply affective manner. They did so with care. The field of knowledge on CFS is still nascent. Biomedical research is only just beginning to untangle the many things that cause and characterize this illness, and clinical protocol for dealing with patients is being made and remade as new information emerges. And despite this, there is a huge body of knowledge that has received almost no scholarly attention, almost no published acknowledgement. That is the knowledge acquired by CFS sufferers from living with the condition. By asking how are you coping, I hope to have highlighted some of the struggles and strategies important to my participants. I hope that in years to come, we will see them move to the front and centre of work on this condition, and I hope that in the meantime, this project has contributed to their efforts to do so.